Mental illness can be seen as a condition that affects a person's thinking, feeling, or mood. It can impact how someone relates to others and functions each day. We now understand it as a complex interplay of biology, environment, and personal experience. However, if we travel back in time to the 1960s, the picture was far less clear. The mind was often viewed as a mysterious, almost separate entity from the body. When it went wrong, the reasons were deeply shrouded in mystery and fear, leading to approaches that seem profoundly alien to us today. People did not have the language we possess now to speak of their inner worlds. In the mid-20th century, society held many powerful, often damaging beliefs about mental illness. It was not commonly seen as a medical condition in the way we view diabetes or heart disease. Instead, it was often framed as a moral failing, a weakness of character, or even a consequence of poor upbringing. Families might hide a relative's condition out of shame, fearing the stigma that would surely follow. The lines between neurological disorders, psychological distress, and simple eccentricity were blurred. A person experiencing what we might now identify as severe anxiety or depression could be labeled as simply hysterical or melancholic, with little understanding of the profound suffering they endured. This lack of clear understanding heavily influenced the medical community's approach. Doctors and psychiatrists were grappling with a puzzle using incomplete pieces. Some theories pointed to genetics, suggesting that mental instability was inherited. Others, influenced by Freudian psychoanalysis, looked for the roots of illness in repressed childhood traumas and unresolved internal conflicts. While these ideas were not entirely without merit, they often led to a narrow focus, sometimes blaming parents or past events for conditions that were, in fact, biological in nature. The brain itself, the physical organ, was a frontier that science was only just beginning to map with any real accuracy. This environment of fear and scientific uncertainty shaped the very places where patients were treated. Large, isolated institutions, often called asylums or state hospitals, were common. They were built to house vast numbers of people deemed unable to function in society. The goal was often more about containment than cure. Patients were removed from their communities, living lives dictated by strict institutional routines. The focus was on managing behavior rather than healing the individual person. Inside these walls, a person's identity could easily be lost, replaced by a patient number and a diagnostic label that defined their entire existence, overlooking the unique human being within. One of the most common tools for managing difficult or agitated patients was seclusion. This was not the quiet time a person might choose for themselves. Instead, it involved placing a patient in a locked, often bare room, sometimes for hours or even days. Doctors believed this would calm an overstimulated mind and prevent the patient from harming themselves or others. However, the experience was often one of terror and profound isolation. Cut off from all human contact, patients were left alone with their distressing thoughts. This sensory deprivation could worsen their condition, leading to increased paranoia, anxiety, and a deeper sense of detachment from reality. Electroconvulsive therapy, or electric shock therapy, was another prominent treatment. It involved passing an electrical current through the brain to induce a seizure. In the 1960s, this procedure was often administered without anesthesia or muscle relaxants, making it a physically traumatic event. Doctors observed that it could sometimes lift patients out of a deep, unresponsive depression, but they did not fully understand why it worked. For the patient, the experience could be terrifying. The memory loss that often followed, both of the treatment and of events surrounding it, was a significant and distressing side effect. It was a blunt instrument used to reset a mind that had gone awry. The 1960s also saw the rise of the first generation of psychiatric medications. Drugs like Thorazine or chlorpromazine were hailed as a miracle, a chemical lobotomy that could calm the most agitated patients with psychosis. These early antipsychotics did reduce symptoms like hallucinations and delusions, allowing many patients to be managed outside of constant seclusion. However, these medications were powerful sedatives with severe side effects. Patients often experienced a Thorazine shuffle, a zombie-like state with slowed movement, a flattened emotional response, and a profound sense of inner restlessness. They were calmer, but at the cost of their vitality and personality. These three treatments, seclusion, ECT, and early medications, form the core of psychiatric care in many institutions. They were all aimed at controlling behavior rather than understanding the person's experience. A patient who was loud might be secluded. A patient who was catatonic might receive ECT. A patient who was agitated might be heavily medicated. The treatments were applied based on external symptoms with little regard for the inner world of the patient. The individual's story, their fears, and their humanity were often secondary to the goal of maintaining order within the hospital walls, a quiet ward being the measure of successful treatment. A fundamental problem in 1960s mental health care was the profound misunderstanding of patients' symptoms. What we now might recognize as a panic attack with its racing heart, shortness of breath, and feeling of impending doom could be dismissed as a bid for attention or simple hysteria. The complex, disorganized speech of a person with schizophrenia was not seen as a window into a fractured thought process, but as meaningless nonsense. Doctors, working with limited diagnostic tools, often misinterpreted the outward signs of an illness. They saw the behavior, but not the suffering that drove it. A patient's refusal to eat might be seen as defiance, not as a symptom of severe depression or a delusional belief. This misinterpretation led to a failure to address the genuine needs of the patients. A person's need for safety, connection, and understanding was rarely prioritized. The institutional environment was often cold and impersonal. Patients were expected to conform to a rigid schedule, with little room for individual preferences or emotional expression. A patient crying out in distress might be seen as a disruption to be quieted, rather than a human being in pain seeking comfort. The very act of expressing their illness could lead to punishment or more aggressive treatment, teaching them to suppress their true feelings and withdraw even further into themselves. A tragic irony. The power dynamic between doctor and patient was incredibly skewed. Doctors were seen as the ultimate authority, their judgment rarely questioned. Patients, on the other hand, were often not believed. Their descriptions of their own experiences, their fears, their physical sensations, the side effects of their medication were frequently discounted as part of their illness. If a patient complained that a medication made them feel empty or unable to think, a doctor might assume this was just another symptom of their depression, not a valid effect of the drug. This left patients feeling powerless and unheard, trapped in a system that was supposed to help them, but instead invalidated their reality. This lack of understanding caused immense, though often unintentional, harm. Treatments designed to help could end up being punitive. A patient locked in seclusion for being agitated would only become more frightened and desperate. A person whose personality was flattened by medication lost their sense of self, the very thing that treatment should aim to restore. The system often stripped away a person's dignity and autonomy. By treating the symptoms as the problem rather than as expressions of an underlying condition, the medical establishment of the time failed to see the whole person. They were treating a chart, a diagnosis, but not the human being at the center of the storm. Comparing the practices of the 1960s to today reveals a profound shift in both understanding and approach. We now possess a much more nuanced view of the brain and its connection to mental health. Brain imaging allows us to see the biological underpinnings of conditions like schizophrenia and bipolar disorder, moving them firmly out of the realm of moral failure. Our diagnostic manuals are more detailed, helping clinicians differentiate between various conditions with greater accuracy. Most importantly, the focus has moved from mere containment to recovery, emphasizing therapy, community support, and the patient's active role in their own healing journey. Today's treatments are a world away from the blunt instruments of the past. While ECT is still used for severe treatment-resistant depression, it is now administered with anesthesia and muscle relaxants, making it a much safer and less traumatic procedure. Modern psychiatric medications are far more targeted, designed to work on specific neurotransmitter systems with fewer debilitating side effects than their predecessors. Most critically, medication is now almost always paired with psychotherapy. Talking therapies like cognitive behavioral therapy empower patients with tools to understand and manage their own thoughts and feelings, a concept largely absent from the 1960s institutional model. The most significant change, perhaps, is the growing emphasis on the patient's voice and human rights. The The principle of nothing about us without us is gaining traction, meaning that patients should be partners in their care decisions. Support groups and peer advocates, many with their own lived experience of mental illness, provide a level of understanding and solidarity that was once unimaginable. We are slowly dismantling the stigma that forced so many into the shadows, encouraging open conversation and recognizing that mental health is an essential part of overall health. The lonely, isolated asylum is being replaced by a network of community-based care. In looking back at the 1960s, we must do so not with judgment, but with a solemn respect for those who endured these misunderstood treatments. Their experiences are a powerful reminder of the human cost of fear and ignorance. The path of medicine is paved with past mistakes, and in psychiatry, those mistakes were etched onto the lives and minds of vulnerable people. By remembering this history, we honor their struggle and reinforce our commitment to a more compassionate, informed, and humane approach to mental health care. We have learned that healing the mind is not about controlling it, but about understanding and nurturing the whole person.